This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of post-op care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together, no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today, we're going to be looking at stroke recognition in pre-hospital care with Shane Devlin and my brother, Ronan Walker. So, few diagnoses in pre-hospital care carry the same urgency as stroke, but not all strokes are the same. And indeed, they do not always present the same way. And that's where some of the fundamental risk can lie. So in this episode, we're going to explore the challenge of recognising posterior circulation strokes using both clinical insight and lived experience. So I'm joined by Shane Devlin. Shane is a registered paramedic and newly appointed PhD researcher focused on posterior stroke recognition, and his work really builds on frontline experience and the growing body of evidence that highlights just how easily these patients and these diagnoses can be missed. Alongside Shane, we do something slightly different in this conversation. We're going to actually get a personal story from my brother, Ronan Walker, who had a posterior stroke 4 years ago. So his presentation really didn't fit the traditional mould of a fast stroke, so a fast positive stroke, but rather more subtle, evolving symptoms which required a different kind of clinical suspicion. So in this episode, we're going to unpack the limitations of current assessment tools like FAST, the cognitive challenges clinicians face in the field, and also what needs to change to improve recognition. Welcome to the podcast, Shane and Ronan.
Thanks very much. Thanks for having me.
Ronan, I'm just going to get your story actually for listeners and viewers. Could you maybe just unpack that day 4 years ago, just to, I guess in a way, paint a picture of like maybe some of the abnormal or atypical signs and symptoms that happened?
So I woke up in the morning and just had a splitting headache. And when I went to the bathroom, I went to flush the toilet and I realised I missed the handle. And at that moment, I thought I was having a migraine, because I didn't have any peripheral vision around here. And I'd had migraines in the past where I'd kind of, you lose a little bit, it kind of feels weird here. So I thought I'm having a migraine. But the headache persisted, it didn't shift. And then I remember we were due to drive all the way down from Bakewell to the South Coast that day. And after lying down on the settee for like 3 or 4 hours, I realised I wasn't in a fit state to drive. My head was still pounding. The peripheral vision hadn't come back. I felt quite nauseous, but at that point I still thought I was just having a migraine, although it would have been worse than anything I'd had before. I was in the back of the car as my wife was driving, and I remember trying to say something to her, and it was almost like it just came out as gobbledygook. And then I kind of went to sleep. And at that point, she knew something was wrong. We stopped halfway down because I needed the loo, and I just remember zigzagging across the car park thinking, this isn't good. I'm just still thinking it's just a dreadful migraine. We managed to get back down to the South Coast, and I just went straight to bed, hoping that I'd wake up and that it would resolve itself. I woke up the next morning. I still had no peripheral vision, which worried me. So I called 111. They recommended I went down to A&E. I went to A&E and had a fairly typical experience in A&E where you end up sitting there for hours on the hottest day of the year. I remember I couldn't read anything whilst I was there because I couldn't focus at all, because the peripheral vision just meant that I couldn't really. I was like having to do this if I wanted to look at anything or look out the corner of my eye like that. When they came to assess me, they checked for all the classic strokes of. They were checking my grip, and my grip was fine. They were looking at my features, and after being there for hours and hours, they said, "Well, we don't think," because obviously what I was talking sounded like a stroke, but it didn't look like a stroke. So they just said, "We're gonna send you home. We don't think there's anything wrong with you." At that point, I said to them that 4 weeks prior, I'd actually banged my head quite significantly. I'd had to go to A&E because chasing one of my little boys in the playground, banged my head on some equipment. Made a right mess of my head. And they didn't scan me. So I said to them, well, I hit my head 4 weeks ago and I didn't get a scan. Could you do that? And she was very reluctant. So she went to see a supervisor and they said, oh, okay, we'll give you a scan. And then at that point, after I had the scan, they came back and said, oh, you've had a stroke. We found a blood clot.
In your posterior,
Yeah, blood clot back here. And then the clinician took me in and he did something where he stood far back from me and he put his arms out like this and he says, tell me when you can see my hands moving, and was doing this. And I couldn't see this one at all.
So for listeners rather than viewers, Ronan's putting his arms out laterally in it and then tweaking his fingers just to test for peripheral vision. Yeah.
And on one of the sides, I couldn't see his hand moving, just couldn't see it. And like, oh yeah. And then he showed me the scan and showed me the blood clot at the back. But it wasn't picked up in any of the assessments. It was only until I got the scan.
Yeah.
But on hindsight, I can see now that they were checking for what would be a classic stroke symptoms of sagging face. Or it was mainly the motor functions they were checking for with me. But yeah, if I didn't press for a scan, they were quite happy to send me home.
Yeah.
But obviously, I knew something wasn't right, and it took about 2 weeks for my vision to return. So I was very grateful because obviously in that moment you're worried it's not going to come back. I developed a stutter that lasted quite a while actually, because it was almost like my mouth wasn't working as quick as what my thoughts were. So very bizarre. I had a stutter for a long time actually.
And they put you on aspirin and something else, or?
No, they initially just gave me an aspirin, but they put me on a proper blood thinner.
Yeah.
After that, and statins.
Yeah. Okay.
And I had about 2-3 days in hospital.
Yeah.
But being 40 years old, I was by far and away the youngest on the ward by about 40 years.
You were on a stroke unit?
I was on a stroke unit, yeah, and everybody was quite senior on there. I was very young in comparison.
Yeah. So Shane, just hearing that story, we've spoken offline, and you've published both empirical and anecdotal literature, case study literature on posterior stroke and these abnormal atypical symptoms. But just listening to my brother, what does that sort of bring up in you?
Yeah, look, Ronan, that's mad. And to chat to you now, like I was saying, you wouldn't know you'd had a stroke at all. So it seems like you've recovered really well. So that's brilliant. I'm delighted for you. But that's really worrying for you as well, that you were in the hospital, wondering, would your vision come back? Would you be able to read or walk properly? That's really worrying. I suppose things that are jumping out for me is that, people aren't going to pick this up if they're not aware of it. It's like that old phrase, the eyes can't see what the mind doesn't know. So when I started looking into this stuff, I was saying to myself, God, how many posterior strokes have I missed? Because when I was very junior paramedic, if I didn't know I was looking for it, I would never have known that I'd missed it, do you know? And traditionally, like you were saying, like whoever assessed you in the hospital there, or stroke tests are more geared towards the big anterior strokes at the front of the brain. So that's when your face is drooped, you've got a weakness down one side, your speech is really slurred, and it's more vivid, I think, of a stroke because it normally happens in a larger blood vessel. But because this type of stroke happens in the back of the brain, it affects things like your coordination, your balance, your vision. And the thing that makes it really hard, I think, is that could be due to so many things. I mean, you said there, Ronan, that you got up and you had a headache. Sure, that could be dehydration, or you might have a little infection or an ear infection or something like that there. You could have ate something funny before going to bed the night before. Sometimes you might have orthostatic hypotension, so you might be lying in bed and you get up too fast and then you're a little bit dizzy and maybe feel a bit sick from that. What makes it really hard is that those symptoms are really non-specific and they're really subtle, and we would just pass those symptoms off a lot of the time, So I think what's really interesting is that it's not that the FAST test is bad. The FAST is actually really, really good at picking up strokes in the front of the brain. But I think it is probably time now that, especially from healthcare provider point of view, we need to be doing a little bit more than that, and sort of expand on from that. Really interestingly, actually, when they were developing the FAST test, the earlier papers in the early 2000s, they actually did consider putting in posterior stroke assessments into that, but they were worried about the paramedics spending too long on scene, with the ethos, get them to hospital as fast as possible. So it's not that they didn't think about it. It was, we need the paramedics to recognise a stroke quick and get them into hospital fast. But in cases like yourself, I'd say you're probably one of the luckier ones, Ronan. Like, other people, despite maybe spending a little extra bit of time on scene to do some extra assessments, other people mightn't be as lucky and they might not get the vision back.
Shane, I just wondered, so a question really would be, for people listening, because like you said, these symptoms are so atypical and they're so vague in a way. But there is some clear trends and maybe uniting themes. One of there's an acute onset, and it's just extremely atypical from baseline. But to your point, the FAST test won't pick this up. So these patients like Ronan are typically FAST negative. What could maybe clinicians hang their hat on, or indeed think, there is still some red flags here, some clinical red flag symptoms that we need to maybe press. Maybe they don't, they are so vague that they don't trigger the FAST tool, therefore they maybe don't go to a hyperacute stroke unit, but that we should maybe start to stream these patients into A&E with just clinical suspicion. What in your minds can we maybe hang our hat on?
So if I'm thinking of headline, big picture stuff, if listeners could take away one thing, it would be walk your patient. So that's obviously with a couple of caveats. Say you've taken your vital signs first and they're not hypotensive and you think you could do a walking assessment. If you get that patient to get up by themselves and I wouldn't really help them as much as I could. So before they called 999 or 111 in the UK, whatever, you would assume that they could get up out of their chair and walk to, say, open the front door, So when you're making your assessment, you've done your blood pressure, you're happy enough that you could do a walking assessment on the patient. Just say, Ronan, would you mind just standing up and just walking over to me here? And literally just observe them. So if they're trying to get up and they can't, but they could before, that's a little bit of a red flag. And then say if they're getting up and all of a sudden they're off balance, they're swaying, or they might sway to one side, that's another red flag. And then, I would probably advocate for, normally it's a dual crewed ambulance crew that goes out most of the time, that either paramedic or EMT is either side of the patient, just in case they do fall. But just try and observe them walking, and they might be all over the place. So that might look like a few different things. So they might appear like they're drunk. They might be staggering everywhere. Or what you can see sometimes as well is that it's sort of like staggered steps. So it's like the patient's legs are very heavy and they're almost shuffling. So depending on the age of the patient, like Ronan, you should be able to walk really well, fit young person, but sometimes an older person, it might be harder to assess their walk. So you're using the history from the patient and their family or caregivers, and you're saying, does Mary normally walk like this? And they might say, absolutely not. She normally walks absolutely fine. So if there's an acute change in their walk, that would be a red flag for me as well. And I'm just writing up another qualitative study where I interviewed 10 posterior stroke patients, and something came out of it was really interesting, I thought, is that a lot of them, when describing that they couldn't walk, they described the need to reach out for something. So to reach out to the wall, to reach out to a chair, that they couldn't walk. They couldn't walk in an empty space, if that makes sense. They needed to hold on to something. So a lot of people described going chair to chair, or they were hanging off the wall in order to open the door or whatever, you know. So if there was one headline thing, I think that's a big thing for pre-hospital staff to walk away with. And I think, and like I said, I don't know how many I've missed in my career because previously I didn't know about it. But when I was a very junior paramedic, you really wanted to be super nice to the patients. Not that you don't want to be nice now, but I remember if a patient was sitting in their bed, you'd take in the carry chair and you try and get the carry chair as close to the bed as possible so that the patient didn't have to take one step, and the family would be like, well, you're mighty. You are mighty. You're a great man altogether. But now what I've sort of said is like, come on, I need to see you stand and walk. And sometimes the patient or the family might say, are you not going to bring a chair in for my mum or dad or whatever? And you just have to explain, this is just part of our assessment. We need to see your mother or father walk because this is really important. And I know it sounds simple, like just get them to walk, but by getting them to walk, you're testing the patient's coordination, their balance, their vision. I mean, are they walking into something? You're sort of unknowingly to yourself testing a lot of stuff by just getting them to walk, you know. So that would be a real headline takeaway there. But other things that are easy enough to learn really is just simple tests for coordination. Now, Ronan, I don't know, they probably did it to you at some point, but did one of the doctors put their finger in front of your nose and asked you to touch your own nose and then touch the person's finger and then back? Did they do that?
Yeah, they did, yeah.
Yeah, so that's a real good test for just coordination, and it's fairly easy to learn. So basically, you put your finger in front of the patient, and whatever hand you want to do first, you get the patient to touch their own nose, touch your finger, and go back to their nose. And then you just maybe move your hand to the side and get them to do it again. You're simply testing their coordination. So what you might see there, you might see when they go to touch your finger again, that they're really shaky like that, and that'll be called an intention tremor. But then another thing is that they might go and they might be missing your finger, which is called dysmetria. So it sounds like you had a dysmetria that morning when you woke up, Ronan, because when you went to press the toilet handle, you missed it, you know. And it doesn't have to be that formal for older patients as well. So sometimes older patients with arthritis and they might have bad shoulders or breaks, you know, they might have some issues maybe understanding the test, and then maybe the strength of their arms, they mightn't be able to do that. But little simple things that you're just testing their coordination is like you might sometimes unbutton the top of their shirt, maybe to put on a 3-lead ECG. And you're not being mean, but you might just say, Mary, would you just mind buttoning your shirt up again there? And the family might think, oh, geez, what kind of lad are you that you took the buttons off and you're not rebuttoning them? But you're watching, you might see that they don't know what to do, and they're trying to button their shirt that they normally can do, but now they can't. So I would count that as a positive test, even though they mightn't be able to physically do the finger to nose as well, if that makes sense. Other little things, like there's a lot of things you can test without making it a formal test. So if the patient has their bag or their phone or a glass of water or something on the table, you might just say, Mary, would you mind just handing me that phone there for a second? And they might miss that. And then that might just prompt you to do maybe some more formal tests, you know. The things then that you said about your vision as well, absolutely what that doctor was doing. A simple one is just putting your hands in the 4 fields of vision, and you just get the patient to look straight, and you might just move a finger like that and get them to point and do the next one, and then, you know, move to the lower 2 fields of vision, and you're moving again and get the patient to point. Another one, I don't want to confuse listeners either, but you'd be looking for a nystagmus, which is the beating of the eyes. So what I do is just get the patient to look straight. And what I normally have to do there is even hold their chin, because when you're moving your finger, a lot of the patients will move their head, you know, when you're moving your finger. So you might hold their chin, and you're basically just making a hitch with your finger, and you're just watching what the eyes do. And if you see the eyes beating rapidly side to side, I would say that's a worrying symptom as well for it. But, you know, as Owen was saying there, you're piecing it all together. If this has happened acutely, as in they were fine 1 second and not fine the next second, that would be a real red flag. You'd be not less worried, but if something's been happening for a couple of weeks and it's really vague symptoms, and I'm on tablets for a urinary tract infection, and I've had a runny nose for 6 or 7 days, and, you know, it's less clear then. But sometimes what I do say or do for patients and their family is that you really want to nail down when they were last well and when this happened. So sometimes I do, like, when I'm asking the question, I might say, were you fine 1 second? Then bang, like I might clap my hands and like, were you not well then? Because to me, if you think of the underlying pathology, I just think of it like plumbing. There's pipes going to your brain, and there's blood traveling to the brain absolutely fine 1 second, and then bang, there's a blockage, or a bleed, and the next thing the blood flow to that part of the brain has stopped. So that's what causes this really acute symptoms in the patient, you know. So I would say that's really worrying. I mean, without even doing those tests, we had a patient one time was just sitting watching TV and had finished his dinner, and then all out of the blue, just room started spinning and he started projectile vomiting. So for no real reason. So, like, before I even done any of the tests, I was thinking, God, this really sounds like a posterior stroke, you know, because why? You're just trying to make sense of everything, really. I mean, if he started puking because he cooked fish that was lying in the fridge for 3 weeks, well, that makes more sense than it being a stroke. So, I mean, for example, if someone is dizzy, lightheaded, the room is spinning and they can't walk, but then their blood pressure is 60 systolic, well, that makes more sense than it being a stroke. You know, so there's a bit of investigative work to go on as well. But I would say, sort of headline stuff, if someone was absolutely well 1 second and then has these neurological symptoms the very next second, it's a massive red flag. Sorry, that's a really long-winded answer there, probably very confusing, sorry.
No, not at all, Shane, not at all. And I think it's really helpful because essentially what you're articulating is the acute onset, the word finding difficulty, and so it might not be slurred speech, it might be difficulty finding words, like you said, Ronan, you were speaking gobbledygook almost, and in that time. But just that quick onset, abnormal gait, ataxia, as you were saying, just maybe an acute dizziness, which doesn't leave the patient, but symptoms which really don't fall within the traditional diagnostic set, but actually are acute in nature, haven't got, to your point, Shane, a clear line of diagnostic inference. So you can't say it was the fish in the fridge because it wasn't, because that's not there's no root cause that would prompt this outside of something maybe a little bit more serious, acute and potentially neurological. Shane, as we just progress through the interview, I just wondered if you could, because we are going to put in the show notes both your empirical research and your anecdotal case study research, because both are fantastic, both really signpost clinicians to start to think differently about this. You spoke about the finger to nose test. Could I get you to speak to the 5Ds and the BFAST? Because, like you said, what we want to do is we want to really start to not only look at those 80% of anterior strokes, we really want to start to articulate that 20% of posterior strokes.
The way I would look at the 5Ds is like they're symptoms to look out for in the patient that might prompt you to do extra tests, maybe beyond FAST, Right, so the 5Ds, and I'm not great at the mnemonics, as I said there, but diplopia, which is double vision, dysarthria, issues talking, dystaxia, issues walking, dysphagia, so issues swallowing food or water, and then
dizziness, yeah.
Dizziness. Oh, yeah, dizziness. So yeah, I don't like. For me, mnemonics are really hard to remember. So, and we're always talking about dizziness with posterior strokes, but if you do see these things, it would just maybe prompt you. So those are really symptoms. So a symptom is something that a patient will experience, but a sign is something that you as a healthcare provider can pick up on, if that makes sense. So the person might say that I'm all over the place or I can't walk, but then what you might observe and what you might note in your clinical exam is the patient was ataxic. So that's the sign that you've observed from that. So that might prompt you to do, well, you should always do your FAST test in these patients anyway, because a certain percentage of posterior stroke patients will have FAST elements in them as well. And like you said, Ronan, you developed some speech issues as well. So really the on the ball clinician might even call you FAST positive, even though it was a posterior stroke, if that makes sense, And then before we go on to stuff that's additional to the FAST test, the way that the FAST test is taught, I feel, means that a lot of people will miss there's a lot of low hanging fruit there that people can pick up on. And what I mean is that you may have, so let's start with F, facial droop. But sometimes that's not really obvious. So when you look at the patient, their face might be somewhat symmetrical, but see this line here, that's called your nasolabial fold. And really it's your laughter line, but see the way it makes sort of a shadow there in your face. What you might only notice is that one side of that shadow isn't as prominent as the other side. So that's a really subtle sign of a facial droop, you might say. The next thing is arm. So we're normally taught arm weakness, and it's normally this real, you put your arms out and it's a real dramatic fall, but it might be something really subtle. So it might be just the patient's really struggling to keep the hand up. Their eyes should be closed in a way because it might affect the test. Another way to do that is put the hands, the palms up like this here, because it requires an extra wee bit of strength to have your palms facing up the way. And what you might see is like the patient's palm might just go slightly up that way because the muscles aren't as strong there because of the stroke now. And what a lot of people don't realize about the FAST test as well, I mean, it doesn't really take into account numbness or paresthesia down that side. So your right-hand side, your face might be numb, your arm might be numb, your leg might be numb. But as per typical FAST test, that patient may be FAST negative if you don't have that weakness. So I think, testing like, does this side of your face feel the same as this? Does this arm feel the same as this? I mean, that would be another one to look out for. Like you're sort of adopting the FAST test to pick up some subtle stuff, again, ruling out other things like if someone was sleeping on their arm all night and their arm was numb, you're like, well, okay, that has sort of maybe blocked the blood flow to the arm and that's maybe why it's a little bit numb. But if someone was going about their normal day business, and all of a sudden their arm is really numb for no real reason, it should prompt you to paint that picture or do more exams, if that makes sense. The other one then is speech, and you touched on it there as well, Ronan. We were typically taught slurred speech as if you were drunk, and then as you see more strokes throughout your career, the word finding comes into it a little bit. Then you might ask a question, how are you today, Ronan? And you might say Friday, and they're not answering the question that you've asked them. So any abnormality in speech at all should be counted as a positive fast. And interestingly enough, speech abnormalities was the number one reason of missed strokes in a big systematic review a couple of years ago, which is, you think it's shocking, but it's not as obvious as you think. We had a patient there recently that appeared to be talking okay to us, and it wasn't until his wife met us at the hospital, and she said, "Why are you talking like that?" And I said, what do you mean by that? And she said, "My husband is using language that he doesn't really use. So instead of saying, I drove my car to work, he might have said, I got in my vehicle and made my way to work." And she was like, "You don't talk like that." So on talking to her afterwards and talking to the patient, he was trying to say, I drove my car to work, but he couldn't find the words. So he had to create another way of making that sentence. So talking to the patient's family and just really like, is that the way they normally talk? And if it's not, well, that's positive and treat it as a stroke until proven otherwise, So that's even just going on the fast test. You can sort of buffer out the fast test a lot more without going into the extra tests, Then you mentioned BFAST then, that's basically just adding in those balance and IE assessments onto the fast, So that's getting the patient to stand up and with a paramedic or an EMT either side, getting the patient to walk and seeing if they can walk. Now, sometimes it'll be really obvious. There's a thing called truncal ataxia. So if you're sitting up in the bed, if you get them to stand up, if you get them to sit up in the bed, straight away they'll lean to the side. You don't really need to get them to walk because they've already demonstrated an ataxia at that point. And then the eye thing then, that can be as simple as, what's your vision like? Can you see 2 fingers, 4 fingers? That's just, is your vision blurred? And then, what patients will do a lot of the times, they might say, my sight is bad for a long time and I've been meaning to get new glasses and I was to the optician, and they might describe a problem that's happened, over the period of a year, but that's when you need to help direct the patient and you're like, was your vision fine 1 second? And then bang, was not fine the following second, So you sort of have to bring them back into the room a little bit for some of those questions. And then the other assessments with the eyes, like I was saying, you're testing for your nystagmus and your visual fields then, and that will help catch the vast majority of them then. Now, what will probably happen is we're probably going into a space where it is starting to happen is that those tests may be very sensitive for stroke, so they might pick up a large amount, but then they might also bring in a lot of false positives as well. So you might, as a paramedic, then be bringing in patients like that's not a stroke, But I suppose from the pre-hospital perspective, you need to cast the net out quite wide in order to help funnel those patients into the right hospital, maybe a stroke centre, so that they can be picked up by the stroke physician and hopefully funneled even more for further treatment then. So I think for pre-hospital, it's about having something that's really sensitive to cast the net out, a real decent sized net to pick up these patients, to bring them in and help funnel them into their specific care. And there's just something that I wanted to make a point on as well that's really interesting. Have you heard of the OMI sort of paradigm shift with ECG and STEMI recognition in the States? So a couple of doctors over there, including Stephen Smith, a great cardiologist, they're sort of making a move to not call STEMI a STEMI anymore. And the reason being is that if you're only looking for ST elevation on an ECG as a sign of a heart attack, well, you'll only see ST elevation on an ECG for a heart attack. And they made a nice argument in one of their papers. It was, you can't really call a disease after the test that's used to test for the disease, you know? So, if you're talking about a STEMI, and you might say, well, the patient didn't have a STEMI, but they got a stent. We're like, well, okay, but they did have a heart attack. So if you think the same, so I'm sort of comparing it to FAST as well. You can't really call a stroke after something that you test for a stroke. So if we sort of start moving, not moving away from FAST, but thinking outside the box from FAST, so just because a patient is FAST negative, it doesn't mean that they're not having a stroke. And I think definitely as a junior paramedic, it was a very binary decision for me. I was like, strokes are easy. I mean, this patient is FAST negative, so it's obviously not a stroke. And I was like, why are people getting panicked about this? But then as you go throughout your career and you have these subtle signs and symptoms, and you might follow up on a patient, and the stroke nurse or the doctor that you're talking to, they might say that dizzy patient was actually a stroke, and you might go, oh my God, but they were FAST negative. So what in that patient would lead me to think that a similar presentation is a stroke? So just like the STEMI shift in the States, I think there does need to be a shift over the side of the water as well. If we're only thinking of FAST, we will not think of the other stuff, So do you know the way that you might do a posterior ECG for ST depression that you might see in the anterior leads? So you put your dots on the back of the patient and look for ST elevation there. These extra little tests is like the posterior ECG for stroke, I think. So it's just about just having that index of suspicion and doing these extra tests as well, if that makes sense.
Yeah, listen, I really like that, Shane, because like you said, it's a nice comparator because, like you said, you're just doing something where you're kind of visualizing or indeed testing something which otherwise would go untested. And to your point, and even to your earlier point around the subtleties of arm drift, the subtleties of facial droop, the subtleties of word finding, and or slurred speech. It's actually not, like you said, it's not the complete absence of something. It could be just a subtle deviation. It could be just a slight change in how they are. And to your point, the relative is a good baseline because they know the patient. They live with the patient. It might be the brother, the sister, the mother, the father, and actually resourcing them as a baseline and as a consistent comparator for how they're deviated, acutely so today. But it's fantastic. That's a great comparator. Just as we pivot, actually, and come in to land on the conversation, Shane, Ronan, just bring you back in. If you could just maybe speak to, because your posterior stroke wasn't the end result. Could you maybe unpack the resulting tests you had about your heart surgery and maybe the reason for the posterior stroke, something that you weren't aware of?
Yeah, so they couldn't tell me definitely what caused it, and they found it unusual the fact I was so young and I had it. But one of the tests they did was I can't remember, it's like a bubble echo, they call it, something like that, where they put some bubble saline solution into my veins, and then they got me to kind of press down, and they noticed that there was a hole in my heart, a small hole, and they said that we can't definitely say this is what gave the stroke, but that was their best guess. So as a result of that, I needed to have, I don't know what the surgery is called, but they basically went in through my groin, keyhole surgery, and plugged that hole. So they think that was their best guess at why I had the stroke, was a small hole in the heart.
Yeah.
So that was a few years ago. I had that surgery now to close that up.
Yeah. And so it is, to your point, Shane, there's often subtle cues that even the patient might not be aware of, like Ronan wasn't aware of the fact he even had a hole in his heart initially. And the first he knew about it was this acute presentation of headache, word finding, and or gobbledygook, and or acute dizziness, and altered gait. And that led down the pathway of investigation to potentially what was the root cause. Just as we come into land, Shane, just if I could get you to speak to and maybe unpack for us, hearing my brother's case, could I get you to really maybe unpack what you feel needs to change the most? Would it be education? Would it be tools? Would it be the culture within pre-hospital care? What are some of these fundamental mind shifts that need to take place to raise awareness, really?
On the education, but I think, platforms like this, like your podcasts, is massive, because even if someone's seen on Spotify or Apple your Spotify episode and posterior stroke is on the title, they might go, there's a posterior stroke, like what's, and that just might, that all of a sudden prompts them to go look it up. And then without even listening to the episode, they might just, they might go to a dizzy patient and they're like, hold on, I've heard about this posterior stroke thing and I looked it up then. Like just the simple awareness or knowing that it exists is actually half the battle. So like my wife, Amanda, she got a nice Kia Sportage last year, but she wanted this particular colour. It was this like metallic green colour. I was like, oh, that's amazing. Like we will be the only people driving this car, And then when we got the car, like we seen all this metallic green everywhere. So basically, when you see it once, you will see it multiple times then. So once you know what you're looking for, you will then see it, which is scary, thinking, what did we miss before? So the simple awareness and things like this is great. So thanks a million for setting it up. The tools then, that's a tricky one then, because there's been nothing really validated for pre-hospital care yet. BFAST is gaining traction, surely, but then a lot of it isn't standardized, as in what is the standardized way to assess balance, what is the standardized way to assess ISO. There was a great webinar from the Royal College of Paramedics there recently about stroke, and I believe his name was Joe Dent. I think he's an advanced practitioner in stroke. He had a lovely line in it, and he said a stroke tool or a clinical tool should only really back up your education and your assessment of a patient. So if you've done your assessment and you've noticed that they're ataxic, they've got an intention tremor, they've got a left-sided visual neglect, have the confidence to say that you are your working diagnosis is a posterior stroke, and then your tool might back that up rather than you solely relying on that tool, But then to the last thing you said there about the culture and stuff, I done a study a couple of years ago which involved focus groups about posterior stroke recognition by paramedics, and something that was really apparent from the groups was getting the diagnosis wrong and being sort of ridiculed at hospital. And that was sort of, say you ring in a stroke or you pre-alert in a stroke and then it turns out to be vertigo. They were worried about looking the fool, and they were worried about the boy that cried wolf then. And there was a real sort of credibility issue in that. And I think a lot of it comes down to your local relationship with your stroke unit as well. I mean, we're very lucky. So I work in Galway City over in Ireland, the west of Ireland. And we have a great relationship with our stroke nurses in our stroke unit, and they will encourage us and empower us to pre-alert patients that we think are having a stroke. And they will very nicely say, bring them in and we'll make the decision, because they want that net, So that gives us the confidence to do that, So I think the culture shift, you do have to have the bit of clinical courage to hang your hat on. You're like, I think this is a posterior stroke. But what I say to some of my students is that the more we learn and the more that we develop as a profession, the more we'll have to sort of stand over as we bring this patient into hospital. So say, for example, you're worried about some of those symptoms, say that you described there, Ronan. Well, if you do your homework and do a good assessment, and you go into hospital and you tell that story, but tell it well. Like I always thought that paramedics were great, almost like medical translators, so they could really get down to the level of the patient on scene. So that might be an elderly woman or a farmer or someone from a lower socioeconomic group, and they can ask their questions and do their assessment in a certain way and still get the same information. But then when you are transporting that patient to hospital and you're handing that patient over, use the correct terminology then. So say if your case there, Ronan, what you were describing was like a visual, you couldn't see out of the right side of your eye and you couldn't hit the toilet handle. Well, instead of saying that, take ownership and said, this is Ronan, he's say 40 years old. He's got a clear right-sided dysmetria on upper limb examination. He's got a clear right-sided visual neglect, and he's clearly ataxic, which had an acute onset. And once you talk with that terminology, you gain credibility. And the doctors and the team in the hospital, they're like, this person knows what they're talking about. Do you know? So what I would say is, what you see and seen, be able to translate that into a really good clinical handout. Like, for example, instead of go, this patient's like really numb and I'm not sure what it is, just say, this patient has an acute onset of a right-sided paresthesia. And right away they're going, wow, okay, yeah, let's get that scan booked, you know? So being able to translate what you see on scene into that medical story is really important. And I think just to stand over that and take ownership on it. And if it's not a stroke after that, well, that's okay, because you have told your story of, this is my assessment and this is what I've found and this is why I think it is a possible posterior stroke. And that's as much as anybody can ask a practitioner to do, I think. So I think there probably needs to be a little culture shift to advocate for the patient, but it's okay for it not to be a stroke then, if that makes sense. Do you know?
No, absolutely. And to your point around being transparent and vulnerable enough to garner feedback, Shane, but also to your point, have a sense of over triage and maybe you take ownership, but also like you said, just be open to feedback. Be open to the relationship of finding what the tests were, finding maybe what the ultimate outcome was, learning from that ultimate outcome, course correcting, but also not worrying if there is a sense of over triage, because to your point, I'd rather that be the case than actually under triage and missing these symptoms, missing these subtle deviations, subtle signs that could ultimately lead to a devastating outcome eventually. So no, you're absolutely right, Shane, and taking that clinical accountability, increasing education, but that relationship and that feedback. But Shane, listen, thank you so much for your time today. We'll put your research in the show notes so people can go away and read it. And I'd love to actually revisit a conversation with you, because you are doing some fantastic PhD work, and actually it'd be really good to revisit where you are in that journey and maybe some of the revelations you're having along the way. But listen, thanks for your time today.
That's great. Thanks, Owen. I really appreciate you asking. Really enjoyed it. And it was great to meet you, Ronan, and delighted that you've come out well on the other side of it. And yeah, it's brilliant to see. So fair play to you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.